Hello, I'm with Dr. Ken Davis, the CEO and President of the Mount Sinai Health System. My name is Dory Cleesis. Today he had a roundtable discussion on the future of medicine, and I'd like to start off by asking about the future of healthcare. Are we moving away from fee-for-service medicine? Is that something we're working toward?
I think inevitably we have to. If we take a big picture and look at the macroeconomics of healthcare, here's what we find. Federal government can't afford Medicare on a continuing basis. Cost is rising too fast. Same is true of Medicaid, and that also affects the states. Employers can't afford their premiums that they're paying or to be self-insured. Employees find that the deductibles and the copays are too high. So everyone says this has got to change, and the government can't afford it. So we're a train wreck in slow motion, and we're going to have to find another way. The way we have been doing this was fee-for-service medicine, in which you get paid every time you do something. Value changed the equation. In value, you make a contract with an insurance company or with Medicaid, the companies that manage Medicaid, or at the Medicare Advantage companies, and they say, we'll give you X thousands of dollars per patient that you take care of. And that's all we're going to give you. And suddenly the economic formula changes. The economics now encourage you to keep people well, keep people out of the hospital, keep people from using services. And that direction is one we're going to have to take in order to make this system more efficient.
Is that better for patients in the long run?
Well, it should be better for patients, but you might recall we had something like this called the HMOs a couple of decades ago, and they failed. And part of the reason they fail is we have to be very careful that there are also quality metrics that are connected to these value-based contracts. Because imagine if the best care is no care. Because the opposite of the fee-for-service system is to say, well, I've got all this money, I don't want to spend it. If I do an imaging study, it comes right out of that money. Every time I do a test, it comes out of that money. If you don't link to it performance metrics, then the system can crumble. But I think we've all wised up to the point that we need good performance metrics and we need to move to value. And I think inevitably that's going to happen.
And how do we incentivize the physicians who have maybe used to something different in the past?
Right. Physicians also have to be incentivized to be efficient. We have to look at how long are their hospital admissions compared to what would be expected of their hospital admissions. What's their mortality? What's their infection rate? What's the hospital-acquired infection rate? There are a number of good metrics that we can look at and compensate physicians for doing well with those metrics.
And we also have to look at the patient, where they live, what they're eating, social determinants of health. Can we cut healthcare costs by focusing more on that?
Well, social determinants of healthcare is a big driver of healthcare costs. What we need to understand is that the United States doesn't spend nearly as much money on social services and what we call that support network as, say, other developed countries in the world. When we look at all that expenditure that we have in healthcare, and we say, look, it's 18% of GDP in the United States. No other country comes close. Well, if we look at it a little differently and say, well, if we add to what we spend on healthcare, what we spend on the social safety net, and we compare those combined numbers to the rest of the developed world, where does the United States stand? And the United States stands kind of in the middle of the pack. And that's about where our mortality statistics are, right in the middle of the pack. So one thing that we have to ask ourselves as a nation, and in particular states and cities, is if we spend more on that social support network, can we really decrease healthcare costs? And what's the best way to do that?
All right, and what about the cost of drugs, the development of drugs? You mentioned a Chronic Disease Drug Act.
Right. Years ago, there was a milestone in drug development, and that was called the Orphan Drug Act. People with rare conditions got together and they said, you know, there's no incentive for drug companies to develop drugs for these small markets. And legislatures, being sensitive to that, said, we have to provide some kind of incentive. And the incentive they provided was to extend the period of market exclusivity beyond what a patent life might be. And the consequence was a whole industry arose around orphan drugs. At this juncture in our country's history, what we have to ask ourselves is, are we developing the drugs for the chronic diseases, the ones that are costing us the most money? And is it time for a chronic drug disease act, a chronic disease drug act, in which we're going to extend patent life, extend the period of market exclusivity for drugs that might diminish the long-term consequences of type 2 diabetes, that will preserve kidney function, that will preserve cardiac function. Shouldn't we say that the first drug that can delay the onset of Alzheimer's disease, which is a terrible chronic disease that costs the country a lot of money and will cost us even more in the next couple of decades, shouldn't we incentivize companies to develop drugs for those chronic diseases?
And let's talk about the future of medicine a bit. Artificial intelligence, do you see a role for it in healthcare?
It's going to be revolutionary. The things that I've seen for artificial intelligence is just extraordinary. I've watched the smart supercomputer that we have at Mount Sinai learn by itself how to read images in radiology, and then ultimately read them with more precision than the expert radiologist. We're seeing the same things in pathology. And in fact, we're marching out a new pathology program in which we're going to be reading slides from all over the world, and a lot of his first pass is going to be done by AI. So yes, AI will clearly help us in interpreting images, whether they're pathological images or radiological images. Question is it going to change, say, primary care? Is it going to help us make diagnoses better? And there are a number of people who are working on that very project. It'll be fascinating to see how AI changes medicine over the next decade.
And Mount Sinai just established a new artificial intelligence center, bringing all the folks in big data, genomics together. So we're working on that.
Indeed, we did. Mm-hmm. It will take a number of floors in a building that we're going to be renovating.
Yes. And finally, as a CEO of a health system, what is your vision of the hospital of the future?
Well, community hospitals are going to have to change, because increasingly what we do in community hospitals, we can now do in ambulatory settings. So ambulatory surgery centers are taking the place of a lot of the surgeries that were done in community hospitals. With telemedicine, people are going to be able to be treated at home. We have a program called Hospital at Home, where 60% of what used to come to our emergency rooms for internal medicine kind of diseases can be treated at home, with practitioners coming to the house, nurse practitioners, use of telemedicine to really keep people at the house, and they have better outcomes and they're more satisfied. What does that mean for the big hospital centers? It means that they're going to become much more ICU beds, much more places for intensive care, for complex surgeries, for really the stuff that can only be done in a few places.
Terrific. Thanks for joining us today, Dr. Ken
Thank
Davis.
you.